I want to take this opportunity to thank everybody for coming. This is kind of one of the first times we've done something like this, but one of the things that's extremely important, and everybody's going to come across it if you do any sort of critical care medicine, is patients that either need an organ or patients that meet criteria to donate. And most people are not properly educated on how to deal with that. I know most people think that they are, and I've seen a lot of people do it wrong, and we've lost a lot of organs because of that. So one of the things that we thought we would do is we would set up a grand rounds in each of the departments dealing with the proper technique for organ donation. And I don't want to waste a lot of time because I know everybody's on a timeline, so I'm going to introduce Bryn Blair to you, who is from LOPA, and she's going to explain why they're here today and what they're going to talk about. Thanks. I'm back here. I got to make rounds.
Okay. Let me strap in. Good morning, y'all. Can you hear me? Okay. No? Yes. Okay. My name is Bryn Blair. As Dr. Greer said, I'm the Donation Services Coordinator for LOPA. I've seen many of y'all in the hospital. You know, we've had a lot of conversations and done a lot of cases together. Welcome, everyone. We're going to try and be as brief as we can so we can leave time for questions. Basically, we're going to just...
Would you ask them in Conway if they hear you?
Can you hear me in Conway? All right. Is that a good sign? All right. Y'all should have a copy of the presentation and a folder that has an evaluation, which we ask that you please fill out and return to us. And then some communicating death pathway and the catastrophic brain injury guidelines, which we will go over. Our offices are all over the state. We're all over the state so that we can respond to referrals as quickly as possible. Our Shreveport office can go as far south as Alexandria and across the north. So we do cover an expansive amount of territory. Typically, we are in the Shreveport, Monroe area. Our main offices are in Metairie. That's where our hub is, and but we are everywhere so that we can respond as quickly as possible. Our goal is to get to referrals within 2 hours. We participate in the same law. We adhere to the same laws and rules and regulations that you do, and as nurses do. We have to sign. LOPA has to have a written agreement with a hospital in order for them to receive Medicare funding. All deaths or imminent deaths must be referred to LOPA in a timely manner. That usually falls on behalf of the nurse taking care of that patient. Hospital staff is trained by LOPA on all donation issues. For example, new nurse orientations, general orientations, new employee orientations. We have a lot of orientations at University Health. Any in-services, physician education that we do. Any individual who provides information about donation to a family must be a trained designated requester. That is LOPA personnel. We are specifically trained to talk to the families about donation. It's not that we're trying to trump your job. It's not that we're trying to trump your relationship with the family, but we are able to be with them for 24 hours at a time if need be. We know you all are very busy as physicians. You have several other patients. So when it comes time for the discussion of donation, we ask that you please leave that to us so that we can actually support them through the entire process. And this last one is going to be something we hit home here in a little bit. The hospital must ensure that potential donors are maintained in a manner that maintains the viability of the organs. That's going to be pre-donor management. If the patient is a potential organ donor, the patient has to be maintained medically and clinically. So pressors, fluids, you can't just stop everything and allow the organs to deteriorate, because that are lives that are not going to be saved because of that. So that's something that we're going to go into, and it's in your folder, the CBIGs, you'll hear them referred to. Potential organ donors. What's a potential organ donor? When your nurse recognizes that the patient is a GCS-5 or less on a ventilator, they call LOPA. If the patient becomes a DNR or withdrawal of care is discussed, LOPA is called. Ideally, this is done within 2 hours of reaching these clinical triggers. That's so that LOPA can get involved as quickly as possible, assess the patient, see if they are potential candidates, Continue to follow the patient if they're not quite declarable in brain death, or if DNR withdrawal of care is discussed but it's not planned in the imminent future. So this gives us a chance to fully assess the patient and look through the chart and talk with you, talk with the nurses, and see the whole picture to see if that patient is a potential organ donor. All this is in Epic. It does have to be part of the medical record, so when the nurse actually contacts LOPA, they get a very long, like 10-digit number that becomes part of the medical record that says they contacted us. Now the team huddle, this is something that we are very passionate about and wanting to continue and perfect. The team huddle involves the physician, the nurse, pastoral care, LOPA, anyone involved in the care of the patient. So you as the physician, we'll come to you if we're on site and this is a potential organ donor and discuss with you the plans. What are the plans for the patient? What are the plans for treatment and maintaining the patient? Do you have plans to talk with the family soon? Do you have plans for brain death studies? These are things that we're going to get information and share information. We'll let you know what our plan is. Is the patient a registered donor? If they are, ideally we will maintain that patient if the patient is imminent brain death or withdrawal of care so that we can offer donation to that family. The goal of the huddle, like I said, is to develop that clear plan. Our passion is supporting that family. We are there to help support that family. Even if they don't do donation, we are there to support that family. It's a very tragic time in their life. Most of these deaths are very sudden, so we want to be there to help the family through the grieving process and processing their loved one's death. If appropriate, we can do a joint approach. If the family feels incredibly comfortable with you the physician, then maybe we can accompany you to go speak with the family so that they're more comfortable. The conversation of death. This is something that many of our residents and attendings have done. I don't think y'all have really had much interaction with that, but giving the diagnosis of death is a critical point in time. They have to understand, the family has to understand their loved one is brain dead. Brain death is very difficult to process in layman's terms because the patient is laying there, the monitor's going, there's a heartbeat, the patient's warm, the ventilators work breathing for them. It's difficult to process brain death when their loved one's laying right there in front of them and quote unquote breathing. So the language used has to be very simple, very basic, and very direct. We have to allow that family time to accept that. We're not going to talk to the family about donation until they understand their loved one is dead. And that's what they need to know. Their loved one is dead. This is not a coma. This is not, a sedation. This is not anything like that, that their loved one has passed, clinically passed, and that is their time of death. So they have to accept the fact that their loved one is dead before they can ever process the idea of doing donation. And that's something that we want to ensure. So that's why the team huddle is important. We'll get information from you, what the plan is, what the discussion was. If you already talked to the family, how did it go? How did they handle it? Did they understand? And when we go to speak with them, we ensure that they still understand. We make them explain it to us as well. Do you know what was just discussed? Do you understand? And then we try to reiterate if need be. Now, decoupled request is a term that describes separating the two conversations. Most often, if death and donation are brought up in the same conversation, you're going to get a decline. Because they have to understand death, they can't understand donation. So if you as a physician, walk into a patient's room and say, your loved one is brain dead, do you want to do organ donation? Chances are you're going to get a big old no. They need to understand that we're not there to get their loved one's organs. We're not there to steal organs or cut them up or mutilate them, because that is what is the mentality of the patient's family most often. They need to know that their loved one has passed and that we are going to be there to support them. That is our goal. So we ask that the conversations be separate. It is much easier for the family to understand. It's much easier for the family to digest the fact that their loved one is dead without having to worry about surgeries and organ procurement and recipients and all that. Because most often, like I said, the family's view of donation, they see it as, you're going to take them to the operating room and you're going to cut them apart. And of course that is not the case. And we are there to explain the entire process to them. So bridging statements, some of y'all are going to get into those positions where the family, you tell the family, hey, your loved one has passed. They've been declared brain dead, and they're going to look at you and go, well, what do I do now? You know, and I know, you know, you've heard several times when we preach, don't discuss donation with the family. That's the #1 rule of LOPA. Don't discuss donation with the family. It has to be a designated requester. So how can you get about not lying to the family or not discussing donation? We offer bridging statements. You know, do you have any questions about, you know, your loved one's death? I'll give you some time. Somebody will come speak with you shortly to help you through this process. It is a process. You know, brain death is brain death, yes, but it's now a process to go through the remainder of, you know, withdrawing of care and, you know, funeral homes and stuff like that. So it does become a process for a family. So you're not lying to them. You're just telling them somebody will come speak with you about some end-of-life decisions and how to get through the rest of this process. And you're free and clear. You didn't discuss donation. I know it's kind of a generic statement, but it really does help transition you and kind of get you out of, you know, a pickle. Because if you happen to offer donation to the family and it's something that we can't fulfill, then we're in real trouble because we have to now explain to the family why donation can't really happen. So it's important that we all are on the same page before discussing anything with the family. So what we have to offer, our family advocates, myself, we've got 4 others, we undergo extensive training each year. Simulations, actors, you know, day to day, we approach families. We go through extensive training and we have the time. Like I said, y'all have 100 other patients you've got to see. The last thing we want to do is hold up your time in this process. We have the time to sit there with that family for 24 hours at a time if need be to get them through this process. We are there to support that family and walk them through this whole thing. Some statistics from 2013, our consent rate was 63%. That is us approaching. And our untrained consent rate, which is physicians approaching, pastoral care, nurses, anybody involved in the process, was 38. It's important that they have the contact and the conversation with a LOPA personnel so that we can get them through the process. I'm going to turn this over now to Jade. She is our coordinator. Many of y'all may have seen her as well when it comes to maintaining the patient once we've received consent. She's going to discuss what's called catastrophic brain injury guidelines. There's a copy in your folder. It's basically pre-donor management. How can we preserve and maintain the viability of the organs before donation happens? You know, if organs are not maintained, then we're going to start losing kidneys, we're going to lose livers, you know, we're going to lose hearts, and we've had that happen, and it's a complete deceleration of care. We want to maintain the patient as best as we can to optimize what we can recover and the lives saved. So I'm going to turn it over to Jake.
Here's the next slide. Nope. Okay. Oh, I don't like that. I'm going to put this. So important with the microphone. Okay, like she said, I'm Jade Tridico. I'm one of 4 recovery coordinators that you will see when LOPA takes over. Just here for 24 hours managing our patient. Okay. The catastrophic brain injury guidelines, known as what y'all would know as the pre-donor management, we call them CBIGs now. Basically, it helps us sustain organ function. We have about 24 to 36 hours when we start our cases, and so we are keeping the circulation, trying to increase kidney output, and we need your help to keep these organs good while we're in the process of finding matches, recipients for them. We have 2 types of donation. The first one that you guys would be most familiar with is brain death, increased intracranial pressure sufficient to impede the blood flow into the brain, causing cellular death of the brain tissue and or herniation. The second one that you might be less familiar with is donation after circulatory death. Basically, in a nutshell, this one is someone has suffered a non-survivable brain injury or anoxic event. but they still have a little bit of neuro responses left. Maybe they're just barely breathing over the vent, just barely posturing. So in that event, this type of donation gives our families an option to still donate since the patient's not brain dead. And at that point, if a family decides they want to make the patient a DNR and they decide they might want to withdraw care soon, LOPA will come on site, evaluate the patient, and we're trying to evaluate the possibility that when we would withdraw care in a controlled environment in surgery, what's the possibility that they will expire within 120 minutes? With a brain dead donor, we have 8 organs that we can possibly retrieve: our heart, both kidneys, both lungs, liver, pancreas, and intestines. Donation after circulatory death, we'll have lungs, kidneys, liver, and the pancreas. Early intervention, it is essential. Like, we need you guys. It's not just a LOPA process. We are not on site all the time, especially when the patient has not become a LOPA patient yet. A lot of times you get a patient admitted, they become hypotensive, all these several things. They have a catecholamine surge, their blood pressure skyrocketing, and then they bottom out. We need you to help intervene and help us sustain this patient, sustain organ function so that families have this opportunity to have a peace of mind that something good has come out of this traumatic injury, whatever the patient maybe has had. You know, my loved one at least was able to save a couple lives. And after speaking with several donor families, that's the one thing that gives them a peace of mind. So physicians, nurses with respiratory, it just takes a team effort. Avoiding deceleration of care, basically you resuscitate your patient. When the nurse identifies a potential organ donor, this is when we need you. As a coordinator, I might call on the phone. We check on the patient's AM and PM calls, like, hey, how's the patient doing? How's their urine output? If she's like, oh, the urine output's been 1,000 cc's this past hour, I'm like, oh, help. Sounds like they're in DI. So that's when we need you guys to assist us if possible. And I'll go over some of the orders later that y'all probably commonly hear that I ask the nurses to ask you guys to sustain this organ function, especially with the kidneys. You know, they get so dry, and then your creatinine's going up. We're only on site as LOPA when we take over for 24 hours when we start placing organs. We don't have enough time to turn them totally around. So with the help from the hospital and physicians working together, we don't have to totally turn around a patient if they've continued to be cared for and treated. And just one other thing, another reason this collaboration is so necessary. So you identify a LOPA donor and you declare him brain dead, or maybe family needs more time. It can take 48 hours from when they're technically brain dead to declare it until we can take consent, depending on family dynamics. So it's another reason we need your help. Predictable consequences. This is just kind of the order of majority of our brain dead patients flow as far as they have an injury. Like I said, you have that catecholamine surge, your blood pressure is increasing. You can almost predict you're going to have to hang some type of vasopressor because the blood pressure will then bottom out. You'll see the diabetes insipidus, volume depletion. And then if the patient's not being treated and there's no intervention at that time, our creatinine's going up, our liver function is decreasing, numbers are going up, and right there we can lose 3 organs for recipients waiting. Okay, I'm going to go over, these are just a couple of the CBIGs. we do this in ICU. Accurate hourly vitals, intake and output. It's nice to see a trend when we're evaluating the patient. If they've been hypotensive, you know, 60/30, well, how long have they been like that? Because if we can intervene, we might still be able to take over, turn things around. Eyes and nose. It's nice to have accurate intake and output so we know how depleted the patient is, how much we have to use to resuscitate them. Maintain the temperature, 97 to 99 degrees anywhere. I just ask the nurse. Sometimes they forget about it. It's like the last thing you think about until you take the temperature and you're like, oh, they're 95. Like, put a warming blanket on. Like I said, hypotension, they'll bottom out after you see that 200 over, you know, 100 blood pressure due to their herniation. And then we have a lack of our ADH. So for hypotension, our first line of treatment usually is dopamine just because, you know, it helps protect the kidneys, your cardiac output. I believe here for y'all's protocol, the first line will be Levophed. So if we can just be ready for that when you start to see that blood pressure skyrocketing, have Levophed hanging on the side because you know you'll need it. And we try to keep our CVP around 6 to 8. Simple things like a fluid bolus can make a huge difference in keeping our kidneys sustained. If you can do nothing else, a liter bolus will make a world of difference sometimes. We usually, and I would say half normal saline at this point, when you've gone in diabetes insipidus, we got to watch that sodium, you know, 160s, 170s. And so half normal saline, a quarter is even better when that sodium is that high. Just respiratory. Hurdles for adequate respiratory function in the potential organ donor. We're trying to prevent the neurogenic pulmonary edema, atelectasis. You have a lot of injuries that cause the pulmonary contusions, pneumonia, so respiratory, to get them involved is important. Continue to turn them. CPT. It takes a lot. Sometimes we have our patients, you know, they're just laying in the bed, obviously, when they're declared, and so a lot of them develop pneumonia, aspiration pneumonia. So then we have to start really being aggressive in our treatment to try to recruit these lungs for transplant centers to look at them. It's a job sometimes. We got to get our PO2s into the 400s to have a transplant center to look at them and evaluate them for a potential recipient. So part of that in preventing those things would be, like I said, the CPT, the turning them, ABGs, keeping them within the normal limits. We keep our tidal volumes 8 to 10 cc's per kg. It's probably a little higher. Usually it's 8, what we do now. Maybe a little higher than what the hospital would normally do. Maintain the PEEP of at least 5. We put them on 8 when we usually come on site. And then chest x-rays. Like I mentioned, diabetes insipidus, our ADHD is inhibited. It's not being released properly, causing increase in our urine output, hypovolemia, and then our sodium increasing. I tell the nurse usually, hey, call me if the urine increases more than 500 cc's, and that's kind of indicative of when our diabetes insipidus is about to start, and then our sodium increases. I guess I could encourage at some point when you know that this is going to be a poor prognosis for the patient. I know the main concern with neuro and everyone is their ICPs are high. You're given mannitol, 7% sodium. At some point that has to stop when you know they're going to have a poor prognosis. And at that point, if you could think of LOPA and go the opposite end of the spectrum, low sodium fluids, that would help. And we also give, I always mention giving DDAVP 1 mic. usually BID. If LOPA is not on site, we haven't started yet, and that'll help us get through until we can take over with the urine output. Try to keep them like 100 to 250 cc's an hour. Lab. A lot of times you like to understand, stop lab when you know a patient has a poor prognosis, you're not doing anything with them. For us, it's just essential to get that daily, at least a CMP if anything, to look at their BU and creatinine, look at their liver panel, make sure it's within normal limits. So before we approach a family, we know this is what we're up against, and you know, it's hard when you go to a family like the family advocates and they're like, hey, we have a chance to get liver, kidneys, and then when the coordinator comes on site, if the patient hasn't been treated, then I see, you know, total bilirubin, that's 2, and a creatinine maybe that's 2.3, and it'll take a while to try to turn around if we can. And so it's given the family false hope, essentially. Maintenance fluids, we usually ask for D5 with 20 a KCl at 100, and that helps offset that sodium when it gets high. And like I said earlier, urine output replacement, we replace cc per cc every hour. Half normal saline will be your protocol. Sometimes you have to go to a quarter when it's that high. This is one of our examples of a case. You have a 36-year-old admitted with a subdural hematoma, immediately had no neuroresponses. The ER initiated pre-donor management, the CBIGS, was brain dead declared within 24 hours. Before LOPA was able to get consent, the patient went hypotensive, polyuria, had pulmonary contusions. Due to the ER taking initiative, replacing the urine output cc per cc, warming the patient, treating their lungs, the ventilator, and the 100% O2, and starting vasopressin to control their urine output, we were able to get the liver and kidneys. We envision a time when no life is lost due to waiting on a life-saving transplant. With your help, we can get there.
Unfortunately, our donor mom got rained in and no electricity, so she was unable to make it. But I do want to open it up for any questions since we do have a little bit of time.
Can't we tell them who this is?
This is Miss Benita Wilson. Her son Buck was an organ donor actually here a few years ago. She recently met her son's kidney recipient, and it was just an awesome experience. But you know, I think it was Dr. Youssef and Dr. Wadwa that were actually on her case. So it went well. Unfortunately, she wasn't able to make it. But you know, I'd like to open it up for questions since we've got a little time.
I'll start the questions. I seem to sense that the nurse is the gatekeeper. And if that's the case, what are y'all doing to educate nurses?
Nurses are educated at every new nurse orientation, and ICU in-services are given often for new nurses that may have missed the education in a new nurse orientation. Nurses know that they're the first line. They're the ones who are going to notice if that patient is a potential organ donor by meeting the clinical triggers and contacting us within a timely manner. Even if you notice that they are meeting clinical triggers, nudge your nurse, say, hey, call LOPA. We need to let them know. They are educated frequently, weekly, if not bi-weekly.
How many people in this room have seen an EPIC prompt to call LOPA? You mentioned that EPIC is helpful in arranging these matters between withdrawal of care versus brain death or cardiovascular death without ongoing maintenance of things like urinary output and blood pressure. Tell me about EPIC. Are we missing something?
In EPIC, we are instituting, there's a best practice box that will pop up for a nurse when he or she charts a GCSF5 or less. There's going to be a pop-up box that says, hey, is this a potential organ donor? So that's their first clue. However, it only pops up once. So if that patient, progresses to a GCS of 10 and then regresses, it will not pop up again. So it's important that we are kept updated. As far as order sets in Epic, we are instituting, after this Epic 2014 has rolled out and kind of settled down, those CBIGs that she discussed will be protocol. So if you have a patient with a non-survivable brain injury, those are going to be first-line treatments to preserve organ function for us so that we can approach the family. And that should hopefully be rolling out within the next few months.
Will those EPIC prompts be available to physicians or only nurses?
We can work on getting some best practice boxes for physicians. It's a very simple process going through our clinical IT. So if that's something that y'all would like, we can definitely comply.
I think we're happy with nurse prompts, but let's leave it at that. Any other questions? Yes, Miles.
Code status of potential donors.
Miles wants to know about code status for potential donors.
Pertaining to?
I've got a patient who coded during an apnea challenge. What's the correct way to handle it? If I'm trying to declare a patient dead and the patient starts dying on me, should I intervene?
If a patient, in other words, is in a code environment and we think that it's wise just to discontinue the code, what does LOPA think about that?
That would be before LOPA takes over, obviously. I would have to say first thing would be what does the family have them as? If we're in the middle of speaking with the family, we know they're a registered donor. Maybe they've approached you, they want to donate. I would say it would be nice if y'all could code them, but of course they're not a LOPA patient yet. So does that help? I
think it's going to come down to what their code status is at that point in time. If
Right.
they've been made a DNR and y'all are doing brain death studies for us, then that's a different situation. If we've had it where we've been coding patients on the way to the operating room to recover. So the code status, it's going to be more when we talk to the family what they want to do, but once the patient does become an organ donor, code status becomes full again.
Dr. Owens.
So I can yell. On my driver's license, I have a little red dot that says I'm an organ donor. That trumps everything, so that if that's me, then you code me. Because I've already made my wishes expressed. That dot on the driver's license trumps what the family says. My wife says, no, doesn't matter. I'm still an organ donor. So I've expressed my wishes. They're on my license. That's done. So you code that patient because they're defined as a donor. If they're not defined as a donor, and the family is not on board with donation, then at that point you're in a whole different rubric, and there you treat the patient according to what is in the patient's best interest, not what's in the recipient's best interest. But if they're defined as, once they cross that, the river Styx or whatever you want to call it, once you cross over and you've defined that they are a donor, whether they've done it for themselves, hopefully y'all have, everybody, when you do your DMV, put the sticker on your license that says you're a donor, because that's legally binding. Once that's done, then it's easy for these guys to move forward. It's easy for us to make a decision. Outside that, you just got to go with wherever you are in the process, and if they're not if they haven't signed on the line yet, and they've said no code,
Bren, would you paraphrase Dr. Owens' comments and respond from LOPA's standpoint?
Yes, sir. Like he said, patients that register to become an organ donors do make their wishes known. That's their legal way of saying that if I were to pass, I want to be an organ donor. So ideally, yes, that is something that we strive to fulfill. We have, however, run into issues where family is like, absolutely not, we are not doing it. I don't care what my loved one wanted, they are going to fight us hair, tooth, and nail. And, we won't force it upon that family if that's something they are truly passionate about not pursuing, despite the fact that their loved one was registered. Of course, though, we do try to help the family with that process and, you know, come to grips that their loved one has been declared brain dead and does want to be an organ donor. But, you know, Dr. Owings is right. You know, if they've already made their wishes known and we're speaking with the family, code them, you know, ideally to try and get us through the process. Unfortunately, sometimes that does happen. If they become too unstable for a bedside clinical exam, there's always other options. You can do the EEG, cerebral blood flow. You know, those are other options that are non-invasive, that won't require, you know, taking them off the ventilator for any length of period of time, so that they won't cardiac arrest. So there are other options. If you notice the patient is becoming too unstable for an apnea challenge, you maybe go to one of the other options for declaration. Clinical bedside exam is not necessarily necessary for declaration.
I'm confused a bit. If a patient has a little red heart on their driver's license and they come in, bad head injury or whatever, LOPA hasn't really, they're kind of involved, like they've been notified, but the patient's family, having already had a relationship with the team, says, I don't want them coded, but we're trying to figure out if the patient has actually become brain dead, and they do an apnea challenge and they code. Legally, don't we have to not code that patient despite the red heart on there? Because the family's wishes have overturned that. They may change their mind in an hour.
No, the courts have shown that your last will and testament, if you were of right mind, will hold up.
Then why do you ask a family if they want to donate?
Well, what we do is
Time out. Okay, first explain the question, because everybody can't hear Dr. Boykin. So repeat his question and respond from LOPA standpoint, please.
Okay, Dr. Boykin is asking, you know, if the patient is a registered donor, but the family has established a relationship with you, the physician, and said, absolutely not, no, no, we're not doing full code. You know, how can you code them because they are registered? If they have been made a DNR, we can actually, after discussing the situation with you, intervene a little bit sooner. We can maybe arrange a meeting with the family and say, hey, we understand you have made this your loved one a DNR, you're planning on withdrawal of care, you don't want a full code, but they are a registered donor. Will you allow us to do this? And 9 times out of 10, we do get consent from them to proceed, because they may not be aware that their loved one was registered. So if we are in a situation where the patient is registered but, you know, is now a no code, then we can possibly talk with the family ahead of time after all that's been done, and talk with the family to see if there's a potential they will allow us to proceed with brain death studies or DCD if they don't want to do brain death studies or they're too unstable. We can still offer donation to the family through that.
If I were called for a code, I wouldn't know if somebody's driver's license showed that they were a donor or not. What's the physician to do? We don't ask for their driver's license.
If LOPA has been notified of this referral, then we will put copies of the registry in the chart, and we will also...
In an acute code, you will not have been notified.
Right. And in an acute code, we will not have been notified, and unfortunately, we won't know about the patient at all. And it's not something that we can pursue. If it's somebody that comes into the ER in full cardiac arrest, we can't, at that point in time, it's out of our hands. So if these are patients in the ICU that are being maintained, that are progressing toward brain death or DNR withdrawal of care, then that's something that we can intervene.
I see almost no solution to the acute code situation personally. Fortunately, that's not the only scenario that has been discussed here today, so we don't want to focus on the negative of the occasional acute code environment. We want to learn about the other things over which we do have better control. Other questions? Well, thank everybody for coming, and thank you all for coming. Yes, Sean, would you like to say something in closing?
Sorry to keep y'all. My son's over here saying, I already hear you enough, Dad. He decided to take the trip with me. I'm from Lafayette. Sean Paul Harris. I'm a physician and donation specialist. I've been with LOPA for about 13 years, and it's just amazing to see the growth that we've had with the hospitals throughout the state. I can assure you that this is not something that happens in most hospitals and also within other states. You know, one of the reasons of why we're doing this is because last year we did a third-person physician survey because we wanted to hear what doctors, how they felt about donation, what was their perspective, because we want them to be a part of this process. And I know, you know, Doctor said that the nurse is the gatekeeper, but you all are an integral part of this process, and we need you to be a part of our team, and us as a part of yours. And so one of the biggest things that we heard from physicians is that they wanted more collaboration, they wanted more communication, and they wanted more education. And so thus we came up with this CME presentation. It's the first time. I've been with the LOPA for 13 years and we've never offered this. And that was something that was shame on us. You know, we've done education, but nothing formally where we could come together and find what is the best practices so that we could support these families. Because, you know, it is a bittersweet thing. I'm not going to candy coat it. We do talk about death. When we're involved, it's because a family has lost a loved one. And that's something that's become personal to all of us. And, you know, someone that I work with who's become like a mother to me because my mom is not close to where I live is someone who lost her son almost 17 years ago. It'll be 17 years in almost 2 weeks. He was a 15-year-old boy who was starting school. And it was second week into his sophomore year, and he was in the back of a truck. It was a non-moving truck. And 17 years ago, we did crazy things like that, not thinking. And he was talking to a friend of his in a school bus, and he tripped on his book sack, and he fell and hit the back of his head. And his parents were called to the ER, and they had several children, and they were like, well, this is nothing different. You know, we're used to going to the ER, and I have 3 boys, and I'm pretty sure I'm going to end up there quite a few times myself. And when the physician came out outside of the ER and asked for Justin's parents, they rose, they stood up, and they hadn't even seen Justin yet. And they said, you may want to think about organ donation because it doesn't look like Justin's going to make it. And this is before they'd even seen him. Now, this was 17 years ago, guys. This was a neurosurgeon who just wasn't educated on the process. And obviously, she said no. She fired the physician, and she just wanted to see her son. And, you know, and I'm going to try to wrap it up really quickly, but it was their perception on donation was a little bit different because Libby, Justin's mom, had lost her father waiting for a heart transplant. And so Justin and his grandfather were really close. And he wanted to know why his papa didn't receive his heart. And so he wanted to talk, he said, Mom, if more people knew about donation, maybe our papa would live. So maybe we should talk about donation so other people don't have to go through what we did. And so he started like a little campaign of his own, you know, that summer. So she knew what he wanted. Even though she had said donation, she had been approached 3 times before she was able to really absorb what had truly happened to her son. He didn't look any different. He had a closed head injury. No apparent changes. And so later that evening she was able to spend time with her son, and she knew what Justin wanted. And she said yes to donation because he said yes to donation. And because of that, he was able to save 5 lives and give sight to 2. She's met all of the recipients. She's very close with the heart recipient, and it's not that he's Justin's heart recipient. She's a close friend with Miss Marilyn because, you know, they have someone that was special in both of their lives. And the reason why I bring that up is because Libby said the one thing that I took from the 13 years of our relationship, there's many things, but she said, you know what, donation didn't change the fact that he died. That's not something that they could change. But she had a decision of whether or not that death was going to be defined by that moment. Instead, she chose that donation would be because now she knows that her son continues to live. And that's something we get to be a part of together. You know, and through that story, you know, her big thing was talk to the doctors. You know, they're the ones that help save these lives. And I know that we were unable to save Justin's life, but because of people like yourself, she has something every day that she can celebrate. And I just appreciate, you know, on behalf of LOPA, we appreciate the opportunity because this is not something that happens very often, guys. You know, I go through conferences all the time, and there's a fine line between the organ procurement organization and the hospital and doctors, and we don't want that. we want to work together. And this is a very good example of you all giving us the opportunity to do that. And with this, we can change lives. And we have. Y'all have saved more lives than anybody else this year. And it's not because of more deaths. It's because of a better process. And together we'll continue to improve that. So I apologize to keep you a little bit longer than you anticipated. I just wanted to share the story. So.